Hello, doctors. Welcome to ZTalk. Today we have Dr. Umapati Hegde, who is from Gujarat, a very renowned nephrologist who is practicing in Nadiad district of Gujarat. Doctor is interested in clinical nephrology as well as the transplant medicines. So, sir is here today to give us some tips in the management of hypertension for the practicing physicians. Welcome, doctor.
Thank you very much.
So, sir, as you are already practicing there and so many years of experience that you have, so could you please kindly share your experience in terms of management of hypertension? The class of medicine, the class of patients that you get probably are not the same as what the physicians get, but most of the CKD patients are also now seen by the practicing physicians outside. So,
hypertension is common in India, and if you see the percentage is very, very high. And if see the percentage of patients who are controlled on antihypertensive, it's very, very dismal. It's only around 50%. If you start any person on an antihypertensive, only 50% of the patients, they continue medication after around 6 months or a year. That is very bad. So we have to have first as diagnosis, initial treatment. The blood pressure comes. Why he has hypertension? There are so many. All are not primary. The secondary causes are all not there. The kidney is one of them, and endocrine is other, and the third is vascular cause. We have to rule out because these are all treatable causes of hypertension. If you don't identify a disease like kidney, it filters water and it also takes care of the salt. Salt and water are an important components of hypertension. So hypertension, kidney is an important, and it regulates, and the effect of blood pressure, if it is uncontrolled, it is there in all organs including heart, kidney, eyes and brain. So blood pressure is most important, it has to be controlled. The kidney, when it is not functioning, kidney filters. The filter is choked. Your salt is also not excreted, and the water is not also excreted. And it is because the kidney, it leads to something known as an angiotensin. It increases the salt and water reduction. So any person who has an hypertension in a kidney, the first, if it is possible, is the ACE inhibitor ARB. They are the class. So many drugs which are available. And so these are the first options. Ideally to start one drug or two drug. Now, the people say that your best is to start with two drug combination. So if the person comes with more than 140/90 or 150/90, better to start with two drugs so that one drug can affect in only one or two mechanisms. If you have a combination, it attacks multiple, because the mechanism hypertension is not only one, it's more than 5 or 10. So it affects by multiple mechanisms. So the blood pressure control is controlled early, and it is effectively controlled for a longer duration time.
Right. So as we're talking about, medicines now, coming to the pharmacological treatment. So which are the preferred molecules?
So calcium channel blockers and an ACE inhibitor ARB combination is the first. If the person has an edema and he has a hypertension, you can use a combination of ACE inhibitor ARB plus diuretic. Preferably chlorthalidone is better. So you can use a combination. If the blood pressure still exists or high, then you can have a combination of ACE inhibitor, ARBs, calcium channel blocker, and a diuretic, preferably a thiazide diuretic.
So when we talk about this calcium channel blocker, the common notion that comes is that they cause edema. And since I'm sure you must be getting such patients, so which calcium channel blockers, or maybe there are many in the market?
Yes.
So any comments on...
So edema, yes, it's a problem in only around 10 to 15% of patients, but 90% it is not. The calcium channel blocker it's a vasodilator. It acting on the L channel, T channel, N channel, multiple are known. So it is the most effective drug in control of blood pressure. Even in the patient who have an edema, the drug which acts as calcium channel blockers are the main. There are multiple which are available earlier: amlodipine, nifedipine, now the cilnidipine came, azildipine, so felodipine, everything is there. So they are acting by different channels. So L channel, it acts vasodilatation, and it predominantly acting in the vasodilatation, then you get an edema a little bit, but the blood pressure control, it is required. Now, azildipine is in the market, so which acts on the L channel and T channel. So it's basically, it's the L channel on the pre and T channel on the post. In the kidney also, even in the legs, in the peripheries. So in the kidney, when you have vasodilatation, gets the blood pressure get transferred into the kidney. So in the something known as the intraglomerular hypertension, which causes a little bit of proteinuria. But if you control the blood pressure, then the intraglomerular pressure also reduces. So the first and foremost is blood pressure control. So if you can mild degree of blood pressure is there, And if you want to, the proteinuria control can be done by the newer drugs like cilidipine and even azildipine. So azildipine having a T channels on the post, it dilates it. So the intraglomerular pressure reduces, and that will cause reduction in the proteinuria also. And it causes a reduction in the inflammation. So proteinuria is damaging to the kidney. As a large amount of protein which gets excreted, it's a tubulotoxin, causes interstitial fibrosis. So if you can use a drug which controls the blood pressure, and it is beneficial to the kidney and also the endothelial, and it also reduces the all calcium channel. When you dilate, the pulse pressure goes up, pulse rate goes up. This don't cause pulse also to go up. It reduces the rise in the pulse rate, and T channels are there in the adrenal. It reduces the aldosterone secretion. Aldosterone is one of the hormone which causes salt and water retention and also the fibrosis in the kidney and the heart. So it has been shown in the trials the aldosterone level also goes down. So it is one more beneficial effect of azildipine. If first and foremost is blood pressure control. So if the blood pressure is not controlled only one drug, you add an ACE inhibitor ARB along with that, then it has a much better effect. You are acting on the multiple pathways and controlling the blood pressure well.
That's really great. I think it's one drug, but giving multiple benefits at multiple sites. Though we still require combinations, but maybe a single drug also may be effective. So, sir, you're using the single drug here?
If it is only a mild hypertension, then single drug. Otherwise, the combination. Most of the patients in kidney, they require 3 to 4 antihypertensive. Three are required. So we are using a combination. So in mild cases, only one we increase to a maximum level. Otherwise, add on an ACE inhibitor. ACE inhibitors can't. Then we go to other alpha blockers or a beta blockers. We use it, especially in those patients where the creatinine is very high, the high chances of hyperkalemia. So in those patients, we can't add ACE inhibitors. Then we go for other antihypertensives.
So what is the final take-home message for the practicing physicians who are handling the hypertension with?
It's a mild to moderate hypertension. The calcium channel blockers are good, and this has a multiple. It won't cause tachycardia. It won't cause edema. It causes less, is a kidney benefit and even a heart benefit. Endothelial dysfunction is less. So azildipine is a good drug, but if it is not controlled, don't hesitate to add another drug.
Thank you very much.
Thank you very much.